morning, everyone. Hello, hello. We have Dr. Jessica Drummond today, and she is a specialist in not just functional nutrition, but also women's health issues. Hello, Jessica.
Hi, it's so great to be here. Thanks so much for having me.
Thank you so much. Do you get a lot of people that come and see you with SIBO at your institute or in the way that they work with you?
I do. With pelvic pain, there is a lot of overlap between the digestive function issues like IBS, which, as we know, is very often related to SIBO, constipation, IBS with diarrhea, mixed IBS, because pelvic pain is related to many different factors. And I wanted to just make a quick note before all the men on the call run away. There are lots of men with pelvic pain after, prostate surgery or just in general, because pelvic pain is often related to a musculoskeletal challenge. So myofascial muscle and joint and hip issues and pelvic floor muscle spasm and tightness, is a piece of the puzzle with pelvic pain. And so while men don't have ovaries, they certainly do have pelvic floors. And so, just so you know that there is challenge in male pelvic pain, which can also be related to SIBO and functional gut disorders. But for women, it's more challenging to some extent, especially when it comes to looking at the fact that, for example, our gut motility can vary with the menstrual cycle. So a lot of times women's pain, pelvic pain that's related to more reproductive organs is exacerbated premenopause. I mean, not premenopausally, but premenstrually and premenopausally, but premenstrually, if we're looking at a monthly cycle, sometimes just before ovulation or at ovulation, because there are hormonal shifts, or just after ovulation when estrogen drops, there are hormonal shifts that affect gut motility. And then, as you said, there is also what we call organ crosstalk. So if you have endometriosis, for example, which is the number one cause of pelvic pain, you might also have bladder issues like interstitial cystitis. You might also have SIBO or other underlying causes of IBS or constipation. And there is a neurologic interconnection due to the close proximity in the pelvis. I like to think of the pelvis as this bowl where all of these physiologic systems come together: your urogenital system, your reproductive system, which is influenced by hormones, your gastrointestinal system, and the pelvic floor and myofascial systems of the pelvic floor, the lower abdomen, the lumbar spine, and the hips. And really, in my experience, now I've worked with women with pelvic pain for nearly 20 years, what I saw was the missing piece when I was doing this from a physical therapy standpoint, is that in physical therapy, we would kind of ignore the gastrointestinal system, other than proper positioning for bowel movements, making sure people were using squatty potties and, sitting and not straining and looking for prolapses. But beyond that, we were missing the fact that we really needed to optimize digestive function to minimize the irritation that could happen during various times in the cycle, or with things like food sensitivities, SIBO, constipation, and so forth. So I think in a lot of cases, gut issues are overlooked in pelvic pain, but they may actually be a really strong contributing root cause.
Let's talk about how many people you've helped with this issue in your physical therapy, because having you as a physical therapist and then combining that with your functional nutrition background is super, super cool. That is a great combination.
Well, I did work with women with pelvic floor and pelvic pain issues for, I graduated from graduate school in 1999. And, within the first 2 or 3 years after that, I became pretty specialized in women's health. So lots of things: incontinence, lumbar and other orthopedic issues related to pregnancy and postpartum, but saw a lot of pelvic pain because I worked with women in two kind of specialty hospitals where they dealt with women's health issues. So, I mean, in the course of my career, certainly I've worked with thousands of women with pelvic pain.
And what brought you into the world of functional nutrition?
Well, what happened was for me, after the birth of my first daughter, I had a hormonal imbalance and maybe a viral kind of re-exacerbation now that I understand a lot more about this that I wasn't really aware of at the time. So I got really sick. I was fatigued. I had anxiety. I got sick all the time. You know, all these kind of vague complaints that a lot of people that eventually find functional medicine are dealing with. And so I went and eventually I found a functional medicine practitioner, physician, and I went back to school and learned nutrition. But what I realized along the way was just what we've been talking about, that my pelvic pain patients, this was kind of a missing piece because pelvic pain is always related to, well, not always, but very often related to hormonal fluctuations, or like in the case of endometriosis, an estrogen dominant situation, low progesterone, and endometriotic tissue does not have enough progesterone receptors. So even if the blood levels are good, you're still having kind of a functional estrogen dominance, and these gastrointestinal issues. So what I realized from my own experience of balancing my hormones through functional nutrition was that I needed to bring this stuff to my patients with pelvic pain because no one was really talking about that 10 years ago at all. And even now, you know, it's still pretty cutting edge when we're thinking about pelvic pain.
So pelvic pain can be discomfort in the vaginal area, discomfort during sex, discomfort just in general, feeling like, talk to me about that, because some people might be so used to it that they don't even know they would qualify as being someone who has pelvic pain.
Yeah, that's a really good point. So first of all, there's sort of the socialization of girls and women as soon as they get their periods, like, oh, you're going to have terrible cramps and you're going to be like just crushed once a month and you won't be able to do anything but lay in bed and like, just get over it. This is our curse, right? But that's actually not true. You should have maybe a day or two of feeling slightly less energetic, mild cramping. But, you know, even if you're 13, 14, 15, just starting your menstrual cycle, 11, you know, girls are starting earlier, which is a whole other conversation. But if you're starting your menstrual cycle and you have so much pain that you can't go to school, or you over time develop so much pain that you can't go to work, you know, that you're just on the floor with menstrual cramps, that is not normal. And it could be a sign of endometriosis. So bloating, which is also common in SIBO, is also a sign potentially of endometriosis. So there's a differential diagnosis that has to go on there. And sometimes it's both. Very often it's both. So it's not normal to have menstrual pain. So let's start with thinking about, there's actually an organization called the Fifth Vital Sign that, you know, uses the menstrual cycle. If a woman's menstrual cycle is healthy and regular and not particularly painful, and there are normal hormonal ebbs and flows, this is an important sign of health. But if the menstrual cycle is off balance, if it's irregular, if you're amenorrheic, if you're skipping periods, if there's a lot of pain around your periods, that's actually not normal. And it's a sign that your hormones are out of balance, which can have all kinds of other impacts. It can have gastrointestinal impacts. It can have cardiovascular impacts, and certainly pain and just, you know, it's quality of life impacts. So that's one sign of pelvic pain, is actually having cramps, either like for a long time during the month, very intensely, you know, during ovulation, during your period, you know, just lots of cramping. Other signs are just lower abdominal, kind of a heaviness, pain that's chronic. You know, we shouldn't be feeling pain anywhere in our bodies chronically. And then sexual pain right at the vaginal opening, or pain only with sex, more often, well, that can be related to endometriosis. It can be related to interstitial cystitis. It can be related to pelvic floor dysfunction, or it can be vulvodynia, which I see a lot of. And that's a particular, that's pain pretty specifically at the opening of the vaginal canal, which you'll feel like trying to put in tampons or during intercourse, or like you can't tolerate an OB-GYN exam. All of that is not normal. And then bladder issues like interstitial cystitis, where you might have urinary urgency. You might have to get up at night many times to go to the bathroom, and more bladder related pain. And then there's the gastrointestinal pelvic pain, which is, lower abdominal bloating, constipation, things like that. So that's sort of the gamut of what people will feel symptomatically. And the symptoms can spread. You can have pain down into the legs or in the hips. It can be cyclical. It can be all the time. It can be only with sex. It can be wearing certain pants. It can be sitting. There are neurologic issues. So there are a lot of, as I said, all these systems come together in the pelvic bowl, and none of that stuff is normal. If you're feeling any of these painful conditions, there are a lot of tools that we have to help.
I want to go back to, for someone who doesn't know exactly what endometriosis is, can you just do a quick definition of that? And then interstitial cystitis.
Yes, interstitial cystitis. Yeah,
that. So what's the difference between that and a UTI?
Good question. So first of all, endometriosis is when the endometrial tissue lining normally the inside of the uterus, grows outside of the uterus. And so it's sort of like a cancer, except it's not life-threatening. It's quality of life-threatening. So it's like these growths that are in the wrong place, and they can be on your ribs, on your lungs, around your appendix, around your, intestines, abdominal cavity, or just outside or on the uterus. They can be anywhere, these endometriotic growths, mostly in the abdominal pelvic canal cavern area, in your belly and pelvis, but can be in other places too. And then, so that's the definition of endometriosis. And unfortunately, the only way to clearly diagnose endometriosis is through laparoscopic surgery. There is no blood test. There is no, there are other imaging can kind of look for it, but the only way to get a clear diagnosis of endometriosis is through laparoscopic surgery. And I highly suggest finding, if you suspect endometriosis, a skilled excision surgeon, someone who only works with endometriosis excision surgery, to do that surgery, because the kind of surgery you have makes a big difference.
Okay. What's excision surgery?
It's where, they're just being very targeted about about the endometriotic tissue being removed in a very specific and skillful way.
Okay. All right. Now, but those infections.
Yeah. And it's not really an infection. It's just like a growth.
Oh no, the UTIs.
Oh yes.
UTIs,
so, and then UTIs. So urinary tract infections over time can lead to interstitial cystitis. If someone has chronic UTIs, interstitial cystitis is more like the bladder is irritated. And sometimes they can do cystoscopy, where they actually look inside the bladder and see kind of irritated pockets on the lining of the bladder. So sort of like leaky gut of the bladder, but it's quite painful and leads to urinary urgency and nocturia, or nighttime urination. But what I often see in my practice for both interstitial cystitis and vulvodynia is that women have a history of chronic UTIs, chronic yeast infections. Often that overlays with SIBO, and their doctors haven't looked for SIBO at all. And then they've been treated with antibiotics or various strains of antibiotics chronically, and then no longer is maybe an infection showing up, but they are still having the symptoms. And that's when you move out of being in kind of a chronic UTI situation to potentially having either interstitial cystitis if it's bladder symptoms, or vulvodynia if it's more vulvovaginal symptoms from a history of chronic yeast issues or bacterial vaginosis.
So if you have any of those kinds of overgrowth, yeast, or what you just said, that can lead to the other condition?
Well, it's hard to say chicken and egg if it's causing it, but certainly we see in, patients' histories like, oh yeah, I had tons of yeast infections and they were treated. And then eventually no longer did I show up positive on the cultures, but I still had the symptoms. And that's when we start thinking UTI, I mean, not UTI, but interstitial cystitis, IC, or vulvodynia.
And how can you treat those things? Are there easy treatments, or is it just like a lifestyle change that someone would have to go through for that?
Well, it starts like everything else from a functional medicine approach, honestly, optimizing gut health. Because when you have these chronic infections, and really they're not infections, they're like dysbiosis of the bladder, of the urinary tract, of the vulvovaginal canal. So, and I was talking with a colleague of mine who's a gut specialist, and it's like, you've got all these little sub microbiomes, right? You've got your bladder microbiome and your vulvovaginal microbiome and the penile microbiome and the placental microbiome, but you can't really optimize those until you've optimized the core gut microbiome, which is why I think this summit is so important for pelvic pain, because you've got to optimize gut function for two reasons. One, you have to have people being able to absorb nutrients so that they can heal, hormonally, so that they can lower inflammation systemically, so that their immune system can heal. And if they've got SIBO, it's very difficult to absorb nutrients because they also usually have intestinal lining inflammation and leaky gut and so forth. And then if you have colon dysbiosis, to me, that is sort of an underlying challenge with all of these dysbiosis of these sub-microbiomes, if you will. Does that make sense?
It does. It really does. It really does. You were talking about how a neurological factor could be part of this. Is that the vagus nerve?
Well, sort of. When you're talking about the gut microbiome, yes, because the vagus nerve, if it's not well toned, you end up people having high sympathetic tone. So they're chronically kind of stressed, anxious. And so the muscles of the pelvic floor respond with a lot of tenseness and tightening. It's sort of like one of the original terms for pelvic pain was headache in the pelvis. And so if the pelvic floor is constantly like tense and tight, it's sort of like people who walk around like this, their necks are tense and tight, and then they have headache. They don't necessarily have neck pain, or they might, but they're also going to have headache. So if the pelvic floor is holding a lot of tension, anxiety, because there's no down training, we call this nervous system down training, vagus nerve toning, or the vagus nerve is irritated by, the imbalances in the gut microbiome and inflammatory cytokines and all the things that can irritate the vagus nerve. That's how it would sort of directly relate to the pelvic floor. But there are also nerves directly in the pelvic floor, for example, the pudendal nerve and branches of that nerve that can be injured at various times, in childbirth, or, there can be traumatic injuries if someone has like a pelvic fracture, or muscles can be very tight and put tension on those specific nerves. And though the pudendal nerve and its branches and other surrounding nerves can be specifically irritated and cause certain kinds of pelvic pain.
When someone comes to you and you start dealing with their case and they have SIBO, what are some of the first things that you do?
Well, I usually start with an elimination diet because I'm trying to, as you said, take the pressure off and relieve some of the symptoms. Then I'm usually looking at the cause. So does that person have hypochlorhydria? We'll do like a betaine challenge, sometimes we'll add digestive enzymes or add betaine HCl because, there's a reason why they have SIBO. Also, from a physical therapy standpoint, when I have the opportunity to get my hands on patients, you can palpate the ileocecal valve, or at least approximate it, between the right hip bone, ASIS, and navel, and kind of see if there's inflammation in the ileocecal valve. And also, physical therapy can be good for motility. If people there is visceral physical therapy that can help the intestines improve the motility. So, assuming we have a positive SIBO test, I'll do elimination diet, low FODMAP diet in some cases, although that's very difficult in terms of compliance. So I do my best to kind of be a little more specific with an elimination diet. And with pelvic pain, there are so many diets too. You're thinking about oxalates and you're thinking about low inflammatory. So, you have to give people something to eat, but we clean it up the best we can. And then, yes, usually we'll do like the herbal protocols, for example, outlined by Gerald Mullen's study. We'll do that. Protocols. I'm not a physician, so either I'll refer for something like rifaximin or other antibiotics, or we'll do herbal protocols. And a lot of times my patients do have overlap with chronic yeast because they've got that vulvovaginal pain. So we'll do herbal protocols like 3 weeks on, 1 week off for a few months, like 2 to 3 months, because I'm finding that what's happening is a lot of times we take people off grains and we take them off sugar and we do 1 round of herbal protocol, for a month or something like that. And then they're like, great. And then like 3 weeks later comes back, or maybe not that quickly, but soon. So I'm now starting to move into kind of rotating through 3 weeks on, 1 week off, a variety of herbs, generally following Dr. Mullen's research. I don't know how specific you want me to get here, but
we talk about the herbal protocol that he studied all the time. So you're cool with that. We have it all outlined. And everybody, for reference, if you've been watching these sessions and you've been, well, what is Dr. Mullen's study? You can find it on PubMed, but also it is the herbals that were compared to the rifaximin and that were found to be slightly more efficient, and that they did it longer, right? So the rifaximin is usually 2 weeks, and the herbal protocols that Dr. Mullen studied was about a month.
Yeah. Mm-hmm.
That's it in a nutshell.
Yeah. So now we're having, what I'm finding is I'm having to do it even longer in a lot of cases, but I would say, but rotating a little bit. So on and off. But I would say that not always, there are some people that eat really clean. I think it depends a lot on, their overall stress load, whether that's physiologic stress, emotional stress. We have a lot of relational stress challenges in pelvic pain. So, for me, that's where we combine diet, nutrition, making sure the gut function is optimized, hypochlorhydria, motility, good, squatting positions for constipation. And then really looking, I have a lot of additional training in health coaching, because to me, you can't do this in isolation and be successful. You have to think about what are all the pressures on this woman, because if her cortisol is out of balance, her gut's going to be off, so we have to really look at it very holistically when it comes to pelvic pain, because usually there are a lot of factors, everything, the pelvic floor responds to stress, the hormones respond to stress, the gut lining responds to stress. So we have to look at everyone's individual stressors.
Let's just define for everyone what hypochlorhydria is.
Yeah, so hypochlorhydria is low stomach acid.
Chlorhydria. Hypochlorhydria, am I saying it right?
Hypochlorhydria.
Okay,
Yeah.
You say that. I'll
whatever. It just means low stomach acid.
Okay.
And that's kind of a problem now, because I've had some patients who were on, so for example, the allopathic therapy for reflux is put people on medications to lower their stomach acid, so it doesn't, reflux back up theoretically and irritate the esophagus, right? But those medications are meant to be used short term while we're like cleaning up the diet and calming stress and all these other factors, and nobody does that. So I've had patients that are on these medications for like 16, 20 years. So they have no stomach acid left, so they can't absorb B12, they can't absorb protein, they can't break down protein. So we have to wean, that's like a process. We've got to work. Again, I'm not a physician, so I work with their doctors to help wean them off the medications and clean up the diet. And, it's a process, but it's really important, because if you don't have enough stomach acid, every time we eat food, there's bacteria on it, right? And stuff. That's just normal. That's life. But our body is designed to have this system where the stomach acid kills off the bacteria and thus doesn't contribute to SIBO. And if you have low stomach acid for years and years, and it's not always medication caused, but it can be, that's a common issue, then, SIBO is definitely a higher risk from my experience.